Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 312 of our pharmacotherapy series, which majors in cardiac arrhythmias. The first question reads, MNO, a 52-year-old man, is visiting his wife, who is hospitalized for pneumonia. His past medical history is significant for hypertension and type 2 diabetes mellitus. He goes into the bathroom and 2 minutes later his wife hears a dull thud. She calls out for her husband, but he does not respond. After an additional 2 minutes, healthcare workers open the bathroom door and find MNO unresponsive and pulseless. CPR is initiated and a code blue is called. The ECG shows ventricular fibrillation and there is no BP. In addition to CPR, what initial therapy is available? Determining the underlying rhythm disturbance is important because it directs health care workers to follow the Advanced Cardiac Life Support, abbreviated as ACLS, algorithm for pulseless ventricular tachycardia or ventricular fibrillation. This algorithm calls for electrical defibrillation first, but other clinicians should work to establish IV access in case defibrillation fails. Regarding external defibrillation, although commercially available manual defibrillators provide monophasic or biphasic waveform shocks, the biphasic defibrillator has become the preferred device owing to its high first shock efficacy. Most commercially available biphasic defibrillators display the device-specific energy dose range that should be used. However, if a healthcare provider operating a manual biphasic defibrillator is uncertain of the effective energy dose to terminate ventricular fibrillation, using the maximal shock energy setting available is preferred. For second and subsequent shocks delivered by manual biphasic defibrillators, the same or higher energies should be used. For first and subsequent shocks, a shock of 360 joules should be delivered if a monophasic defibrillator is used to terminate ventricular fibrillation. We will now discuss epinephrine and vasopressin. Although epinephrine stimulates beta-1, beta-2, and alpha-1 adrenergic receptors, it is the alpha-1 adrenoceptor effects that are most closely associated with efficacy in ventricular fibrillation or pulseless ventricular tachycardia. Applying alpha-1 adrenoceptor stimulation increases systemic vascular resistance via vasoconstriction, which elevates coronary perfusion pressure. This increase in coronary perfusion pressure is most likely the key to enhancing the return of spontaneous circulation after subsequent electrical defibrillation. Epinephrine may convert fine ventricular fibrillation to a coarse variety that may be more amenable to defibrillation. The recommended dose of epinephrine is 1 mg 10 ml of a 1 to 10,000 dilution. The dosage can be repeated at 3 to 5 minute intervals during resuscitation. If the drug is given IV through a peripheral catheter, which in this case includes a peripherally inserted central catheter, then a 20 ml flush with normal saline is recommended to ensure delivery into the central compartment. Only chest compressions cause blood circulation in ventricular fibrillation or pulseless ventricular tachycardia, so movement of drugs from the periphery to the heart where the benefit will occur, is severely impaired. Vasopressin is an exogenously administered antidiuretic hormone. In supraphysiologic doses, vasopressin stimulates V1 receptors and causes peripheral vasoconstriction. Vasopressin use during CPR causes intense vasoconstriction to the skin, skeletal muscle, intestine, and fat, with much less constriction of coronary vascular beds. Cerebral and renal vasodilation occurs as well. The results of a prospective, randomized, controlled, multi-center study N=1186 that enrolled out-of-hospital cardiac arrest patients who presented with ventricular fibrillation, pulseless electrical activity, abbreviated as PEA, or asystole, showed that administration of vasopressin as adjunctive therapy resulted in similar survival to hospital admission rates, primary outcome measure, compared with adjunctive epinephrine therapy. In this study, patients were randomly assigned to receive 2 ampules of 40 international units of vasopressin or 2 ampules of 1 mg of epinephrine. The second dose of vasopressor was injected if spontaneous restoration of circulation did not occur within 3 minutes after the first injection of the drug. If the absence of spontaneous circulation persisted, the physician administering CPR had the option of injecting epinephrine. The reported survival rates were similar between the 2 treatment groups for both patients with pulseless electrical activity and those with ventricular fibrillation. An in-hospital study of 200 cardiac arrest patients, initial rhythm, 16% to 20% ventricular fibrillation, 3% ventricular tachycardia, 41% to 54% pulseless electrical activity, 27% to 34% asystole, showed no difference in 1-hour or hospital discharge survival for vasopressin 40 units versus epinephrine 1 mg. Similarly, a meta-analysis of 5 randomized trials showed no survival advantage of vasopressin treatment versus epinephrine treatment at the time of hospital discharge or 24 hours after treatment. Since the publication of the 2010 ACLS guideline, some study investigators have focused on assessing long-term outcomes in out-of-hospital cardiac arrest patients. Hagihara and Associates showed that out-of-hospital cardiac arrest patients who received epinephrine prior to hospital arrival had lower rates of 1-month survival and 1-month survival with favorable neurologic function, compared to patients who did not receive epinephrine with a p-value less than 0.001. Similarly, Goto and colleagues showed significantly lower rates of 1-month survival and 1-month survival with favorable neurologic outcomes in out-of-hospital cardiac arrest patients with shockable rhythm, who received epinephrine before hospital arrival, relative to patients who did not receive epinephrine with a p-value less than 0.001. On the basis of these trials, it would be reasonable to use a single dose of vasopressin 40 units as an alternative to either the first or second dose of epinephrine 1 mg in the treatment of ventricular fibrillation or pulseless ventricular tachycardia. The next question reads, one of the physicians delivering ACLS for MNO wants to initiate corticosteroid therapy. What is the evidence supporting the use of corticosteroid therapy in patients experiencing cardiac arrest? A randomized, double-blind, placebo-controlled, parallel group trial performed by Mentzelopoulos and colleagues assessed the impact of using 2 different strategies for managing in-hospital cardiac arrest patients on a. Survival to hospital discharge with favorable neurologic status. and b. probability for return of spontaneous circulation for 20 minutes or longer. One group of patients received epinephrine 1 mg per CPR cycle, vasopressin 20 international units per CPR cycle, and corticosteroid therapy, methylprednisolone 40 mg during first CPR cycle, then hydrocortisone 300 mg per day for post-resuscitation shock for up to 7 days, followed by taper. The control group received epinephrine in combination with saline placebo. Epinephrine vasopressin corticosteroid recipients exhibited superior rates of probability for return of spontaneous circulation for equal to or longer than 20 minutes, 83.9% versus 65.9%, odds ratio 2.98, with a 95% confidence interval of 1.39 to 6.40 with a p-value equal to 0.005. And survival to hospital discharge with favorable neurologic status 13.9% versus 5.1%, odds ratio 3.28, with a 95% confidence interval of 1.17 to 9.20, with a p-value equal to 0.02, compared to the control group. The next question reads, because MNO has an IV site and the time from cardiac arrest to ACLS was brief, epinephrine was chosen and a 1 mg bolus was given, followed with a 20 ml normal saline flush. The arm was elevated for 20 seconds to ensure adequate delivery. 30 seconds after administration a 200 joules shock is given via biphasic manual defibrillator, but it fails to convert ventricular fibrillation. What can be done now? The most recently updated ACLS guideline calls for the use of amiodarone in cases of ventricular fibrillation or pulseless ventricular tachycardia that do not respond to CPR shocks, and a vasopressor. Let's discuss IV amiodarone and lidocaine. The effect of amiodarone on ventricular fibrillation or pulseless ventricular tachycardia was studied in the ARREST trial, which is an abbreviation of the amiodarone for resuscitation of refractory sustained ventricular tachyarrhythmias trial. This study was conducted in patients who experienced cardiac arrest in an out-of-hospital situation with therapy given by paramedics in the field. Patients who failed 3 stacked shocks and 1 dose of epinephrine with an electrical countershock were randomly assigned to amiodarone 300 mg IV bolus or placebo. This was followed by other antiarrhythmic agents historically used in ACLS 2000 guidelines, lidocaine, procainamide, or bretylium, if the clinicians desired. Amiodarone significantly increased the chance of survival to hospital admission, 44% versus 34% of placebo group, with a p-value equal to 0.03, but survival to hospital discharge was not changed. Of note, 66% of patients received antiarrhythmic drug treatment for pulseless ventricular tachycardia or ventricular fibrillation after amiodarone administration, UN. The ALIVE trial, an abbreviation for the amiodarone versus lidocaine in ventricular ectopy, N equals 347 trial directly compared IV amiodarone 300 mg to lidocaine 1 to 1.5 mg per kilogram bolus 0.173. In this trial, patients needed to fail 3 stacked shocks and epinephrine plus an additional shock to be eligible for randomization to either amiodarone or lidocaine. Amiodarone was given as an initial dose of 5 mg per kilogram followed by a shock. If unsuccessful, a dose of 2.5 mg per kilogram was given followed by a subsequent shock. Lidocaine was given as a 1.5 mg per kilogram bolus followed by a shock. If therapy failed, then a second bolus of 1.5 mg per kilogram was used with a subsequent shock. If the first antiarrhythmic drug failed, other routine antiarrhythmic drugs for cardiac arrest per 2000 ACLS guidelines, e.g., procainamide, bretillium, could be tried. Patients given amiodarone were 90% more likely to experience the primary outcome, survival to hospital admission, than those given lidocaine, with a p-value equal to 0.009. Unfortunately, no significant advantage to hospital discharge occurred, 5% versus 3%. On the basis of these findings, amiodarone is the only antiarrhythmic agent with proven ability to improve return of spontaneous circulation and short-term survival versus other antiarrhythmic therapy. However, it has not yet been shown to improve survival to hospital discharge. MNO is at serious risk of death as a result of ventricular fibrillation. However, as long as MNO remains in ventricular fibrillation, it is appropriate to continue active therapy. If MNO degenerates into asystole after this long period of ventricular fibrillation, then the resuscitation efforts should be discontinued. However, if a patient only had a brief period of ventricular fibrillation before having asystole, it is prudent to apply active therapy. The next question reads, JDV is an 80-year-old woman who experiences cardiac arrest in the hospital. JDV was in respiratory failure upon admission to the emergency department, where she underwent immediate intubation, had a peripheral IV placed, and upon transfer to the medical ICU, placed on assist or control mechanical ventilation with FiO2 of 100%. A rhythm is noted on the monitor, but no femoral pulse is felt. JDV is in pulseless electrical activity, abbreviated as PEA. How should JDV be treated? The clinical situation in which there is organized electrical activity on the monitor without a palpable pulse is called pulseless electrical activity. Although electrical activity is present, it fails to stimulate the contractile process. Virtually all patients in true pulseless electrical activity die. However, not all patients who present with a rhythm and no pulse are in true pulseless electrical activity. Therefore, it is important to rule out treatable causes in patients who appear to be in pulseless electrical activity. The major treatable causes are hypovolemia, hypoxia, acidosis, hyperkalemia, hypothermia, cardiac tamponade, pulmonary embolism, acute coronary syndrome, trauma, and drug overdose. In the absence of an identifiable cause, the focus of resuscitation is to administer high-quality CPR, and after the initial rhythm check, resume CPR during the establishment of IV or intraosseous access. Once IV or intraosseous access becomes available, administer epinephrine 1 mg every 3 to 5 minutes or give one dose of vasopressin 40 units in place of the first or second dose of epinephrine, as published studies have failed to demonstrate a survival advantage of either vasopressor for patients experiencing pulseless electrical activity. The next question reads, KSK, a 73-year-old man, has a past medical history significant for hypertension and diverticulitis. Upon arrival at the OR for surgical correction of pericardial and pleural effusions, KSK received etomidate, fentanyl, lidocaine, and succinylcholine. During placement of a double-lumen endotracheal tube, KSK goes into cardiac arrest. The ECG shows a flat line, and the patient is determined to be in asystole. Is this rhythm treatable? Lack of electrical activity or asystole, like pulseless electrical activity, carries a grave prognosis. Its development usually indicates a prolonged arrest, which may explain its poor response to treatment. However, a few patients will go directly from a sinus rhythm into asystole and may be resuscitated. enhanced parasympathetic tone, possibly attributable to a vagal reaction, manipulation of the airway from intubation, suctioning or insertion of an oral airway, or chest compression, may play a role in inhibiting supraventricular and ventricular pacemakers. A post-hoc analysis performed by Wenzel and colleagues demonstrated superior survival rates at the time of hospital admission in vasopressin-treated patients, compared with epinephrine-treated patients. However, no difference in intact neurologic survival was noted between the two treatment groups. Consequently, providers may choose to administer vasopressin 40 units IV in place of the first or second dose of epinephrine, or epinephrine 1 mg IV every 3 to 5 minutes. The next question reads, does the timing of epinephrine dosing impact survival to hospital discharge in patients with non-shockable rhythms, asystole or pulseless electrical activity? A post-hoc analysis of data from the Get with the Guidelines resuscitation study showed a stepwise reduction in survival to hospital discharge, primary study endpoint, with each 3-minute delay to epinephrine. A 1 to 3 minutes OR 1.0 reference group. B 4 to 6 minutes OR 0.91 with a 95% confidence interval of 0.82 to 1.00 with a p-value equal to 0.055. C 7 to 9 minutes OR 0.74 with a 95% confidence interval of 0.63 to 0.88 with a p-value less than 0.001, and D more than 9 minutes OR 0.63 with a 95% confidence interval of 0.52 to 0.76 with a p-value less than 0.001. And the last question reads, what is the long-term prognosis for patients with non-shockable rhythms? Goto and colleagues assessed the impact of pre-hospital epinephrine administration on long-term outcomes seen in out-of-hospital cardiac arrest patients with non-shockable rhythms. Epinephrine recipients showed superior 1-month survival rates compared to patients who did not receive pre-hospital epinephrine, 3.9% versus 2.2%, with a p-value less than 0.001. However, pre-hospital administration of epinephrine did not result in improved 1-month favorable neurologic outcomes with a p-value equal to 0.62. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 313.